I wonder if I can ask you about, the classic patient with lower risk MDS has anemia, and Rami's just described to us how he approaches those patients. But what if you have a patient who has an isolated thrombocytopenia or multiple cytopenias? How do you treat those patients with lower risk MDS?
I'll answer the easier one first. So if you happen to have someone who has multiple cytopenias, potentially RCMD with less than 5% blast, then I think something that might result in a trilineal response would be the way to go. The only drugs that I know of is hypomethylators, even though we all like to kind of wait on this. But again, the prognosis for people who have RCMD is not necessarily so great, so maybe you could make a case for that, particularly if they're transfusion dependent. When it comes to isolated thrombocytopenia, I think that's a very, very small proportion of people who have low-risk MDS and have severe thrombocytopenia, defined differently in different studies. Some look at less than 20,000, some say less than 30,000. But there's very interesting development in this area, even though, like I said, it's a small piece of the pie in this patient population, and that is when it comes to TPO agonists or thrombopoietin agonists. Now, many of you may be aware of the initial study that looked at romiplastim and sort of randomized patients with low-risk disease and platelet count less than 30,000 to either romiplastim or supportive care, and that study actually was based upon some encouraging data on improvement in platelet count with these agents, which is, sort of logical. But then again, the study was held because of increase in the percentage of blasts in the peripheral blood, as well as increase in the degree of fibrosis in the bone marrow. Now, interestingly, when the drug was held, the blasts went back to the bone marrow, so I'm not exactly sure if it was necessarily disease progression, but needless to say, this was not an option. However, recently at this past ASH, another very similar trial was reported, this time using an alternate TPO agonist, and that is eltrombopag, in a very similar patient population, very similar design, demonstrating actually that there is a reasonable response rate in those patients who have severe thrombocytopenia. So it's kind of encouraging, but I still would like to see longer follow-up, and I would certainly not try to do this off study. That would be my recommendation.
So we participated in the romiplastim study, as I believe
yes.
You did as well. The initial phase 1/2 study was really encouraging. It showed response rates in the 40 to 50% range, and those response rates were actually recapitulated in the randomized phase 2 study. The problem with it, of course, is that the study enrolled patients with excess blasts, and blasts have TPO receptors. Yeah. So among those patients who transformed to AML, and there was a group of patients who transformed to leukemia on that study, 3/4 of them started out with excess blasts. Now, you'd expect, as you've mentioned earlier, some patients with lower risk MDS are just bound to transform to leukemia. It's going to happen. So the others were probably expected based on the population. It is very tricky to use these drugs now, given those data. So I will occasionally use them, but I will tell you it's about a 30-minute discussion with my patients about the risks of using them, and I really try to search for some sort of immune-mediated component to MDS and thus platelet destruction to justify that sort of off-label use.
I agree with you. I wonder, I wonder how many of those people actually do have an autoimmune mechanism for that degree of thrombocytopenia to take place. I often would try like a pulse decadron before I actually go on and try Promacta, but
as a test.
Yes.
Right. Yes.
So we had an ongoing study with eltrombopag for almost 2 years. We just closed, and we treated more than 40 patients. So I think exactly to what you are saying. First, we were including everybody after hypomethylating agents failure, and clear if you have high-risk disease, that those patients progress quickly, that you cannot even see if there is benefit. You cannot tease out whether the drug is contributing or not. So I think at this point, if they're going to be used in the higher risk, they probably should be in combinations. In the lower risk, there is definitely a subset that you see benefit. And we've had patients ongoing on the study for 2 years, platelet transfusion independent, doing very well. Interestingly, even in the Italian study, there were some complete responses or trilineage responses similar to the aplastic anemia experience. One thing we observed in our study is that patients that had CMML, particularly if they were proliferative, were more likely to develop leukocytosis, fibrosis, circulating blast. So that's a group, if they have proliferative CMML, I will shy away from using eltrombopag, even if they are lower risk. And I think the French group had similar experience. But a lower risk where you think it's isolated thrombocytopenia, I think that's a very appealing option. I hope that the follow-up on the Italian study will show us safety in 1 or 2 years, that becomes a available option for patients.
Yeah. Ellen, we've mentioned a bunch of drugs that we try on patients with lower risk MDS. When do you determine that a drug has failed a patient? And of course, we all agree that drugs fail patients. Patients don't fail drugs.
Well, I think that the drugs fail patients when the patients are not, when they become transfusion dependent to the degree that they were either starting out or maybe even much more than when they started out, when their lifestyle is absolutely, completely overrun by the disease. So that their performance status, their time in clinic, their rate of infection, shows that they are not benefiting any longer from my treating them with a particular drug. So it may be that patients are persistently neutropenic and they develop infections where obviously, long-term use of this drug has not prevented that problem, or they were not particularly transfusion dependent, have become transfusion dependent and are maybe receiving weekly blood transfusion. When patients are thrombocytopenic to the point that they may be needing transfusions once or twice a week, or have episodes of bleeding. So I think that patients fail the drugs when they're no longer efficacious in treating their symptoms.
And the rule in MDS, whether we like it or not, is that we continue drugs until those drugs failed patients, right? So there is no 6-month course and then you stop, or 4-month course and then you stop, be it lenalidomide or one of the hypomethylating agents or the cyclosporin portion of ATG therapy. We just keep going until the patients reach one of those parameters you just discussed.
But I wonder if you guys see the same thing in your practices too. Often that's not necessarily recapitulated in practices. I often see people who had been treated and the treatment was stopped because the patient responded. Well, if they responded, it's actually more logical to continue, but somehow that doesn't necessarily happen. And I don't understand exactly why this is the case.
And you see the other way, that ESAs
Right.
are continued long time after they, they
Failed.
stop working, right? So I think when I look at failure, I look at a primary or secondary treatment failure, like patients not responding from the get-going versus somebody having a response before and losing it, which sometimes is easier to tell, like, hemoglobin went up, they were transfusion independent. If they would go back transfusion independent, that's an answer. What I struggle with, and like sometimes many patients refer to us, they start with hemoglobin 8.5 and they got 8 to 12 weeks of ESA and it's still 8.5 or 9, and the argument, at least they are not getting blood transfusions. I was really not sure always if this is a success of the treatment. Like I always try to get also the quality of life of the patient. Is he feeling better now than before? But that's a little bit murky area in how to assess failure, ESA failure, if hemoglobin didn't go up, but they are not getting transfusions. So.
It can be tricky. It can be tricky. And, we don't want to rest on our laurels by saying stable disease is a win, right?
Right.
I think if we're starting a patient on a drug, we need to see some improvement and not just assume that stable disease is somehow a benefit of that drug, because we all have patients who've had stable disease for years without any therapy.
Any treatment.
Absolutely.